Hello, I'm Alex Abbott. I'm a pediatrician turned primary care sports medicine physician. So I have a unique expertise in taking care of young athletes with all kinds of sports injuries. I help take care of athletes through college age, and adolescents have important nuances to consider when one of them comes limping into your primary care or acute care clinic. Today, I'll introduce the topic with some of these unique nuances to teenagers, and I'll provide an overview of what we see most commonly. I'll discuss overuse injuries like growth plate injuries and bone stress injuries, some acute injuries, especially common fractures in adolescents, and then we'll wrap up with a more zoomed out perspective of what teenagers are facing socially as they navigate being student athletes. You might be tempted to treat teenagers, especially those reaching college age, as adults with less life experience. However, despite the possibly intimidating child with a beard who's towering over you in clinic, his musculoskeletal anatomy tells a completely different story. With the same injury mechanisms as adults, open growth plates, or physes, represent weak points in the chains of forces that are applied to the same systems. These growth plates are also with variable strength. They're weakest during the periods of high growth velocity, so they're more susceptible to injury during growth spurts. On the right, you can see an adult, a teen, and a child pitching. The adult and the teen look similar and may both present with medial elbow pain, but inside, the teenager's differential looks closer to the child's. Namely, we think about the strong UCL ligament, the ulnar collateral ligament, being affected in adults when that growth plate is closed on the medial epicondyle. But with an open medial epicondyle physis, the teen pitcher's weak point is more suggestive of apophysitis or an avulsion fracture, depending on the story and what your x-ray looks like. In addition to these sort of dynamic structures that depend on the growth periods, the variable hormone changes in boys and girls affect muscular growth rates, bone density, and other systemic variables such as sleep and tissue recovery. Growing pains, they aren't just for little kids. Teenagers' bones grow disproportionately compared to their muscles, and during those growth spurts, they have a flexibility problem when they don't have a good stretching program. Teenage athletes might talk a big game to you and when they come to clinic talking about their elite sport participation, but in general, compared to adults, they're inflexible, they're still developing motor skills, they're still working on coordination and core strength, or not working on those things because they're just focused on playing, and they haven't learned yet everything that they can learn about balance and proprioception, and all of these things can mitigate injury risk in most sports. The physiology is not all bad for teenagers, though. Their upregulated growth systems and their childlike thick and vascular periosteum in the bones allows them to still benefit from amazing fracture remodeling. It's not as robust as younger children, and you can see from these examples of fractures that we still get really robust fracture healing. So this 14-year-old on the left, we have a clavicle fracture, pre and post. This is non-surgical management with some pretty good remodeling at the 4-month mark and expectation for continued remodeling with time. And then sort of similar results on a proximal humerus fracture in a 13-year-old, and then a distal fibular fracture. We would call that a Weber C fracture because the fracture is above the ankle mortise on the fibula. For an adult, that would certainly need surgery, but teenagers still get away with some remodeling. Adolescents also demonstrate faster healing for tendon overuse injuries or tendonitis, and we'll talk about that later. So if you take away just one thing from this talk, even though these boys and girls may come in with excellent bone structure, unique haircuts, and legs that are heavy enough to make you question your arms routine, the adolescents that you see in your clinic are not little adults. This year, we'll publish a comprehensive study that characterizes the epidemiology of musculoskeletal complaints from a cohort of over 60,000 pediatric patients. This cool figure from our study shows visually how the top 3 injury sites were shifting as children are in different age groups. As they age, the sites become different. They seem to go from falling off of changing tables as infants to playing sports and gaining coordination, with time to stretch out their extremities and to injure more distally. However, the example of the fibula fractures only being in the adolescent's top 3 sites likely reflects the common distal fibula avulsion fracture, which is a common fracture sustained when a big kid with open growth plates rolls his or her ankle. We'll talk a little bit more about this specific fracture type later, but this important intersection of risk factors, the big forces and the weak growth plates, is illustrated well in adolescents who sustain this injury especially. Our study also showed some cool changes in fracture subtype likelihood by age. Babies and school-aged kids have moral reflexes and they play sports where their foosh mechanisms, falling on the outstretched hand, cause torus fractures most commonly in these 2 age groups. The softest bones in the youngest kids are the most likely to green stick or not break all the way through in the infants and toddlers. And again, we see high forces intersecting with the open growth plates the most in older children, contributing to higher rates of avulsion and Salter-Harris fractures for them. Finally, the graphic on the right shows that as boys and girls age, their extracurricular misadventures sort of differ despite similar sport participation. So baby boys and girls are similar in their fracture rates, but teenage boys break their bones more often than teenage girls do. We'll zoom in now to focus on some specific topics, starting with overuse injuries to look out for in adolescents. So when muscles are overused, we call them strains with microfiber tearing, pain, and inflammation. When tendons are overused, they get thicker, they hurt, and they can progress from this acute inflammatory tendinitis to a more chronic tendinosis that we describe, where fibrosis causes scar tissue to form instead of normal tendon tissue. When bones are overloaded past their ability to strengthen with exercise stimulus, stress fractures or bone stress injuries can occur. We'll also talk about the other OCD for bone injuries, that's osteochondritis dissecans, a little bit more detail later. Finally, in adolescents with open growth plates, wear and tear can affect those as well and present as apophysitis or growth plate irritation or inflammation. Overall, all of these tissues can accept exercise stimuli and then remodel stronger, but if athletes don't recover between their exercise sessions enough, or if they load too much too quickly, then the scale tips in favor of damage rather than adaptation over time. Differentiating muscles from tendons when concerned about a strain or tendinitis is mostly a matter of your physical exam. Using the hamstrings muscle as our example here, if pain is very proximal in the posterior thigh or very distal to suggest insertional pain where the muscle becomes tendon or where the tendon inserts into the bone, you might consider tendinitis over a muscle strain diagnosis. If your patient's mostly tender over the muscle belly, you think about muscle strains as your diagnosis. Muscles in general rehab more quickly than tendons, so it's helpful to differentiate those diagnoses. Rehab for tendon strains and tendon injuries is typically more involved, and we're more conservative to try and be respectful of the injury, with trying to avoid complicating it to tendinosis or tendon tears in the future. But muscle strain rehab typically starts with stretching followed by strengthening. With tendon injuries, we're thinking more about a bigger arsenal of rehab and treatment modalities. So rehab would involve special strengthening called eccentric strengthening or isometric exercises to try and stimulate the tendon more. For the hamstrings, if we stick with this example, this looks like the Nordic curls where you're controlling the down, as we describe it, controlling the downward movement and letting the tendon hold on to the load for a longer period of time. When a patient's tendinitis is starting to get into a chronic state and we're worried about tendinosis, our arsenal that I described includes some pro-inflammatory modalities such as nitroglycerin patches, dry needling. We think about tenotomy, shockwave therapy, PRP All of these are done in sports medicine and orthopedics for the very stubborn tendon injury. Using ultrasound can be helpful to differentiate tendinitis and tendinosis, and ultrasound is often used to guide the procedures that I described previously. For our purposes, ultrasound and histology can illustrate how the scarring process of tendinosis that you can see on the right, how with the linear and organized structure that you have in healthy tendons, the scarring process sort of loses that organization and that strength is lost. Instead, we have these sort of ugly blobs of scar tissue that don't contribute to tensile loading and the force that the remaining fibers need so then that scar makes those remaining fibers have to work harder as an athlete tries to remain active. Okay, now, as we've discussed, when the growth plates are affected by overuse, we call this apophysitis. Each of these growth plates close at variable time points throughout puberty, and they're all unfortunately named after people instead of their locations. Monasterio et al.'s 2021 study following over 500 injuries over 10 years in a group of elite adolescent soccer players. They give us this really awesome visual about how peak height velocities seem to correlate in a way that shows that growth plates are active and closing from the ground up. So you can see Sievers at the heel is affecting kids when they're younger, with the error bars furthest to the left on percentage of adult height and thus correlating with younger children. And then more on the right side, closer to 100% of your percentage of complete adult height, the pelvis and the back, like ASIS apophysitis and spondylopathy, that's affecting older children. So overall, this kind of suggests that in this one study at least, that the athletes' growth plates were weaker and probably more active, and thus probably closing from the ground up, but we definitely need more studies to re-demonstrate this pattern before we can call it a rule. Just in case some review is needed to remember the eponyms for the locations of growth plates, Iselin's is at the base of the fifth metatarsal, Sievers is at the calcaneus, Osgood Slaughter is at the tibial tuberosity below the knee, Sinding Larson Johansson or jumper's knee is at the bottom of the patella, that inferior pole, and Little League shoulder and elbow are at the medial epicondyle and the proximal humerus, respectively. I'll show some examples of the axial physes later. Monasterio et al.'s study also helps illustrate a concept that we talked about earlier. Once the growth plates are closed, the weak points in the chains of connections become the muscles, tendons, and ligaments, which were previously stronger than the open growth plates. So injuries at the muscles, tendons, and ligaments become more likely to be injuries that we see into adulthood rather than adolescence with open growth plates. So you can see when they were tracking injuries related to those dynamic structures, they were seeing them more commonly shifted to the right with respect to that x-axis on percentage of adult height. So we discussed overuse of the muscles, overuse of the tendons, and overuse of the growth plates. Now we'll cover some detail on when the bones themselves are overworked. When bones are loaded, similarly to the soft tissues, they can adapt to the stress over time. However, when recovery and/or volume is imbalanced, the breakdown outpaces the buildup, and stress fractures or bone stress injuries occur. Bone stress injuries occur more commonly in adults than adolescents, but a recent 10-year study of over 10,000 sports injuries found that 42% of stress fractures were seen in patients who are younger than 20 years old. Stress fractures are most common in the lower extremities, especially the tibia, fibula, and femur, but they're also relatively common at the pars interarticularis. This is the projection of bone in the posterior part of the spine that takes stress during extension type activities. We also call the pars bone stress injury spondylolysis. The sports where we see stress fractures the most are cross country and track and field, gymnastics, basketball, and soccer. You should think about BSI or bone stress injury. Keep that on your radar for an athlete who is high volume weight bearing or who has a dramatic increase in their exercise volume. And if a patient has a concern based on their history or lab work for low energy availability. So we think about this for very lean athletes. Once you realize your concern for bone stress injury, the first steps are to obtain imaging. As you can see on the right, bone stress injury can be visible on an X-ray, but it's important to evaluate patients with X-ray and MRI to rule out more subtle or early bone stress injury that's not visualized on an X-ray, and or grade a positive X-ray for the prognosis and the management guidance if there is one. I always offer the panel that's described on this slide for blood work to help a patient rule out organic contributors or primary etiologies, essentially suggesting poorly optimized bone health for possibilities with this blood panel once we've diagnosed a stress fracture. This blood work can help you know that if the patient's resting properly, that there's not a primary etiology in the background that's working against you and threatening recurrence of this injury. If a patient's history or blood work is suggestive of low energy availability, or if the patient's amenable regardless, I also will offer a nutritional consultation to help the athlete make sure that they know that they're fueling properly. If you diagnose a stress fracture at the lateral part or the tension side of the femoral neck, and then also the sites, the patella, the kneecap, anterior tibia, medial malleolus, the talus in the foot, the navicular in the foot, the second or fifth metatarsal, and then the great toe sesamoids, these are all considered high-risk sites. So we treat these much more conservatively. This is because of the nature of gravity and weight bearing pulling on the tension sides, pulling those that sort of new bone scaffolding apart sort of chronically. And then with these sites, we also see suboptimal blood flow for some of them. Those factors predispose them to non-union and likely need eventually for surgical fixation. Bone stress injuries are initially managed with rest to allow bone healing. My typical instruction is that athletes can walk without the use of a cam boot or crutch if they don't have pain when they're walking, but I will give them cam boots or crutches or both if the walking is painful. If walking is not painful, I typically defer the use because I want a patient to have buy-in to this sort of long haul process of healing this. And I find that giving patients crutches when they're not painful with weight bearing, they're tolerating weight bearing and just walking, that tends to erode the trust between me and the patient. I also instruct patients that they should refrain from weight-bearing activities, and they can swim and engage in seated core or seated upper body activities for the lower extremity fractures. But I would not allow these activities or recommend these activities for axial site stress fractures like the spine, pelvis, or the ribs. At Stanford, we use an evidence-based protocol for returning athletes with stress fractures who do not require surgery back to their weight-bearing activities and sports. The goals are to allow fracture healing first, followed by progressive loading to prevent recurrences and sort of keep that scale tipped in favor of adaptation and increasing bone density instead of recurrent bone stress. Phase 1 is the unloading phase for initial healing. And then phase 2 involves relevant strength training for potentially deconditioned patients after that initial resting phase. And then we're also in this phase testing the waters gently with longer duration walking over time. Phase 3 progresses athletes further with low impact cardio, weighted strength exercises, and then progression to jogging. Finally, athletes begin the return to running phase in phase 4, with return to sport activities as the goal. The phases overall can take 3 months or longer to complete, and the emphasis for pain-free activities and slowing or halting the progression if symptoms are recurrent is really, really crucial. I describe that to patients that taking shortcuts through the phases by not reporting pain or trying to skip ahead, that can paradoxically make the return to sport process take longer. I also describe that it's quicker to progress through the phases at an appropriate pace, even if it feels slow, than to go back to phase 1 over and over again because of injury recurrences. Okay, so I included the next overuse injury of the bone, osteochondritis dissecans, after our bone stress injury discussion because the treatment is similar and similarly frustrating for athletes. It's prolonged rest. The mechanism for this osteochondritis dissecans, or bone and cartilage dissolving, is not very well described, but it seems to be related to blood flow interruption at an epiphysis of a highly and repetitively loaded bone. Patients can present with chronic pain with OCD lesions that are found radiographically, or they can present with acute injury that seems to have been exacerbated or had a predisposition from an existing low-grade lesion. An important nuance for the knee is illustrated here. The notch view, which is the fourth view of a complete knee series, is often not obtained by providers, but in my experience has been the most important view for clearly demonstrating an OCD lesion radiographically in the knee. If you have a clinical or radiographic suspicion for an OCD lesion, an MRI helps you to grade whether it's low grade, which is up to grade 3, or high grade, which is 4 or 5. High grade lesions warrant surgical consultation given their low likelihood for healing with rest alone. If non-operative treatment is trialed, patients are instructed to rest from impact activities like running and jumping for 3 to 6 months. I typically follow them every 3 months until I see no evidence of the OCD lesion on an X-ray and the symptoms from the patient related to the lesion have resolved. Now we'll move on from the overuse injuries that present without clear injury mechanisms to the common acute injuries in adolescents. You can think about these in sort of similar categorizations based on which structures are involved as the overuse injuries that we covered. So muscles will strain and tear, tendons will rupture, and ligaments sprain and tear. In many cases for muscles and ligaments, even full tears can be managed without surgery, but if you have concern for full tendon tears and then some specific ligaments and some specific muscles, they're too unique in their function, meaning they don't have redundancy with other muscles or ligaments in that area of the body to be able to rely on other structures. These specific nuances include the supraspinatus rotator cuff muscle, which has this habit of shortening over time as the patient heals from the initial injury, and it makes surgery more difficult if there's any delays. The ulnar collateral ligament, or the UCL, in the medial elbow also warrants orthopedic evaluation, especially in throwing athletes. And then any full tears of the ligaments in the knee and any complex acute tears of the meniscus can contribute to chronic pain and instability if those aren't referred to ortho. Dislocations of the shoulder and patella, even if they're spontaneously reduced, even if the patient doesn't seem to have pain afterwards, even if the patient has a party trick of dislocating these joints, those warrant orthopedic consultation because of the high risk for recurrence and then the high risk for ongoing cartilage damage each time that dislocation happens. All of these injuries, these acute injuries, are more common in adults than adolescents. Again, those open physes are weaker than the structures that are more dynamic, these muscles, tendons, and ligaments. And then if you have high force through the chain, the physis is more likely to widen or break completely. On the right, you can see some different examples of these avulsion fractures. The distal fibula is at the top with some variations of subtle versus obvious avulsion fractures. And then the photos on the bottom show different tibial tubercle avulsions, the acute form essentially of Osgood-Schlatter. As promised, here we have the pelvic growth plates that fortunately do not use those eponyms. I included them here instead because apophysitis at these locations is usually quite subtle, and the fractures, visualizing the fractures helps to find those corresponding locations more easily when you're learning the locations. So working counterclockwise from the top, we can see an avulsion of the iliac crest. Below that, the ASIS, which is superior to the AIIS on the bottom. Then we have the lesser trochanter, and then the ischial tuberosity, or the sits bones that attach to the hamstrings on the bottom right. And then on the top right, we have the pubic symphysis avulsion fracture. Okay, so even though I prefaced fractures with all the scary triage stuff, fractures in children and adolescents are genuinely fun to treat because they remodel so well. The most common fractures in adolescents are of the distal radius, clavicle, hand phalanx, and the distal fibula. So we'll discuss each of these higher yield fractures briefly. First, the distal radius. So for any displaced fractures, patients should go to an ED for attempt at reduction. Even if it's minimally displaced and you think it's likely to remodel, the patients who come on day one after their injury should have a fair shot at reduction to minimize how long it takes to heal and maximize the union likelihood. Once a fracture is no longer displaced or it's just minimally displaced, a short arm splint can be placed for 1 week to allow swelling to come and go, followed by a short arm cast or a long arm cast, depending on how much pain they have with elbow motion, especially pronation and supination. If the patient's reliable, you can opt for a continuous removable brace to immobilize them instead of casting. Reliable meaning they're not the 2-year-old who removes anything with Velcro on site, and or the teenager who hides the brace in their backpack and tells their parent they've been wearing it at school all day. So I often ask the parent what kind of child they think they have. If the growth plate's involved for your fracture, as in the Salter-Harris fractures, once that is healed, we still monitor the physis every 6 months for 2 years or until the patient's physes have closed bilaterally. So we use the bilateral radiographs to compare them over time and make sure that the physis that was affected by fracture doesn't arrest prematurely. You can see an example of a subtle growth plate fracture on the top left with asymmetric widening noted on the lateral view there, pointed by the red arrow. You might refer patients with Salter-Harris 3 and above, so 3, 4, and 5, to orthopedics for that monitoring. You might also consider referrals to ortho for patients with intra-articular extension of any fractures, the unstable both bone fractures, which involve not just the radius but also the ulna. Also for fractures that don't show evidence of adequate healing after a prolonged period of immobilization, we're thinking on the order of months. On the top right, this initial green stick fracture returned to the provider after 5 weeks, and you can see from their initial green stick on the left to the 5-week follow-up that alignment was lost at some point during that 5-week immobilization period. This is better to catch early, and fractures should be followed every 1 to 2 weeks until the patient is no longer tender and the x-ray shows good healing. This is called your clinical, no longer tender, and radiographic. X-ray shows some new bone growth. That's clinical and radiographic union, and suggests that the patient doesn't need to be immobilized anymore. Once the cast or the brace, if you're using a brace, is discontinued, I typically instruct patients to work on the range of motion if there's any stiffness that's developed, which usually means waiting about 2 more weeks before returning to sports. This is a big reason why I like using the removable bracing whenever I can. Stiffness isn't usually an issue for a patient who's been gently ranging their wrist and using a brace continuously otherwise. Finally, the photos on the bottom show 2 examples of fractures that remodeled without any kind of surgical intervention in 2 teenagers. This helps kind of give perspective about how teenagers can still remodel pretty significantly over time for minimally displaced distal radius fractures. Okay, for the clavicle, if surgery is not needed, we start them with 2 to 3 weeks of immobilization with a sling, followed by sport restriction, essentially avoid falling down until it's healed. Again, we need clinical and radiographic evidence of union to determine that we're healed. You should evaluate on your initial exam for concurrent shoulder injuries to address any problems with the rotator cuff, and then also a good skin exam to make sure that the fracture is not risk for opening the skin with its sharp edges. On the bottom, I included an example of normal swelling on the bottom left compared to true skin tenting with the photo on the right. I typically advise for clavicle fractures that it's reasonable to return to high-risk sports. These are things like wheeled sports like skateboarding, scooters, bikes, snow sports, contact sports. I like to tell patients to wait 2 months after the fracture is healed to avoid refracture. And then I tell them also that they can consider waiting up to 6 months, which would be reasonable if you want to be on the safe side, based on anecdotal refracture experience. The textbooks will tell you that surgery is needed for patients with clavicle fractures that shorten 2 centimeters or more if the angulation of that fracture is greater than 30 degrees, or if the displacement, meaning the two segments of the bone, are greater than one bone width apart. And this is because these patients have a decreased likelihood for proper healing. However, this important study from 2019 has changed many providers' approach to completely displaced clavicle fractures. Hayworth et al. Followed over 400 teenagers with these types of fractures for 2 years after they either went for operative management or did non-operative management and just let it remodel. Intuitively, the fractures that went for surgery were worse. They more often had shortening above that threshold of 2 centimeters and were more often comminuted or in multiple pieces. The cases that went for surgery had significantly more complications and significantly more needs for revisions or other unexpected second surgeries. But when we compared at 2 years between the operative cases and the non-operative cases, there was no difference for risk for non-union or for refracture. So to consolidate what the textbooks are telling us versus what the patients are showing us in this recent large study, as a primary care provider, I would consult ortho for textbook cases, patients that are breaking that threshold, in order to let orthopedics reassure me that this is going to remodel without surgery. Okay, now the little finger fractures. Similarly to the other fractures discussed, ortho should be consulted for patients with deformities, any fractures that are more than minimally displaced for reduction or surgery, patients that have more than 30% articular involvement, so greater than a third of the joint space is affected by the fracture. If you're concerned for prolonged non-union with immobilization, so you've been keeping them resting for months and it's not getting any better, those are good reasons to send to ortho. You also might consider ortho for oblique or spiral fractures for fixation, because those oblique and spiral type fractures notoriously fall out of alignment because they're so unstable. Dislocated fingers, fractured fingers with displacement, and fingers with open fractures should triage to acute care for reductions and/or antibiotics. If you have a finger fracture that's able to be managed outpatient, usually an aluminum splint provides adequate immobilization and protection. If the fracture is related to the dorsal or the top part of the finger, slight flexion of the splint helps the fracture unite better. And then the opposite is true for volar avulsions, or those on the palm side of the finger. Putting those in slight extension makes that a tensile side and helps it, a compression side, and helps it heal faster. For the thumb, patients need to use thumb spica splints, which also immobilize the wrist, unfortunately. But if the fracture is at the IP joint of the thumb or the distal phalanx, then you might be able to get away with the aluminum splint. But more proximal on the thumb than the IP joint, you need something to immobilize the MCP, that joint between the hand and the thumb, and you can't do that really with an aluminum splint. On the right, you can see how well teenagers remodel phalanx fractures without surgery. I also included the example of a mallet finger on the slide, which is when the plate that anchors the extensor tendon on the top avulses. The patient will show you, when they come in, an extension lag in this case, which is illustrated by the black and white photo in the middle. The treatment for mallet finger is a stack splint, which prevents the finger from falling into flexion at the DIP while it's healing, and you need to keep this on for 6 to 8 weeks to allow for that plate to heal. I tell patients to use their thumb like in a pincer formation to keep the affected finger in extension whenever they're changing or cleaning the splint, and I see them every 2 weeks to ensure progress and find out if that finger has fallen into flexion. If it does, that 6 to 8 week clock starts over again. The mallet fingers are good to refer to ortho given the nuances, in addition to any other finger injuries where you're worried about concurrent tendon injuries with your fractures. Finally, we'll review the distal fibula fracture in adolescents. This is most commonly sustained when someone rolls or inverts their ankle. The lateral collateral ligament complex of the ankle sort of yanks on the fibula downwards during that inversion and typically either pulls apart the growth plate or pulls a chip of bone off from its anchor point on the tip of the fibula. Salter-Harris 1 fractures of the growth plate can be noted with subtle widening on the x-ray, but they're typically clinically diagnosed based on a patient's point tenderness over the area that corresponds to the physis. On the right, you can see the little round marker that the patient placed that seems to correspond quite well to their physis in this example. And then when you scrutinize it further, especially if you've seen these frequently, you can see a very discrete medial physeal widening when you're scrutinizing that growth plate. But if that widening was not obvious to you, as it is very subtle, the patient's point tenderness over the physis could preempt a clinical diagnosis of a Salter-Harris 1 fracture and immobilization and recheck for fracture remodeling in 1 to 2 weeks. If someone comes to you with an ankle injury and is unable to weight bear, you're worried about a fracture, they should be in a cam boot or a short leg walking cast if they're not reliable to maintain the cam boot, and or crutches depending on if they have pain when they're walking in the immobilization. I typically reevaluate these patients in 1 or 2 weeks, like I said, to check for fracture remodeling. And then if that concern for fracture is ruled out, your x-ray looks identical on your follow-up and the weight-bearing issues are resolved, then I'll transition patients to a lace-up ankle brace for protection against recurrent inversion injuries for 1 to 2 months. Lace-up ankle braces have been demonstrated to be superior to other types of bracing and to ankle taping for preventing inversion injuries. So I recommend at least 1 to 2 months to prevent inversions again, but indefinitely if the patient desires for reducing the risk of recurrent inversions. Finally, I also give patients home exercises and a PT prescription for ankle strengthening and proprioception. This is because when someone rolls their ankle or inverts their ankle, they're at risk for doing this over and over again. This is likely because, one, someone who has inverted their ankle demonstrates probable biomechanical deficiencies that they're susceptible to until they get through a PT program, and or because the ligaments that get overstretched during the inversions become more lax or more loose after a sprain. This resource is one that I can't recommend enough. It's written for the primary care provider and it features step-by-step management outlined similarly to how we discussed the common adolescent fractures, but for every bone in the body and not just for adolescents. I know one sports medicine doctor who shamelessly leaves this text open and as they're kind of up to date for fractures in their clinic. Memorizing the orthopedic reasons for consultation or what type of cast patients need is not necessary, especially if you have a reference like this. So we've reviewed how to identify and treat some of the most common overuse and acute injuries in adolescents. Now we'll discuss an increasingly important aspect of injury prevention in young athletes. Over the last few decades, young athletes are choosing to increasingly participate and specialize in a single sport. We think about labeling an athlete as specialized when they compete in a single sport for more than 8 months out of the year and when they don't spend similar amount of time playing another sport. Surveys of kids and their parents suggest mostly parental motivations for this emphasis, with goals of sport and financial success with the mastery of one sport. However, most kids in the United States stop playing all sports when they start high school and they have to make a team, including the specialized kids, and virtually none of them will achieve sports success in the form of collegiate participation after high school. But is sports success narrowly defined as making money from it? Is a young athletic kid who remains a healthy athlete lifelong into adulthood considered to be unsuccessful in sport? So let's say you still want to shoot for that 1%. Does it help you to try to master a sport by specializing? Maybe you can pay off with that 1% certainty. Our studies of elite adult professional athletes, Olympic athletes, these suggest that they were not usually specialized as young athletes. And our studies of Division I college athletes suggest that they typically waited around until around age 16 to settle into a specific single sport to specialize in. The thought is that these multi-sport athletes became successful because they had learned adaptable movement patterns that made them overall more athletic, and they also protected themselves from overuse injuries by cross-training throughout their youth years. So maybe specialization doesn't really help your chances, but does it hurt to try? Evidence suggests it seems like yes. Each of these studies on this slide deserves their own journal club session, but this compilation of 12 studies recently highlights the commonly corroborated association between higher degrees of sport specialization and various types of injury risks highlighted in yellow. The studies from this 2019 analysis led the authors to the concerning discussion point that higher rates of adolescent injuries, such as apophysitis, were apparent with specialization, but also that the degree of overuse associated with sport specialization trends athletes to what we describe as adult injuries earlier in life. Jayanthi uses the example of patellar tendinopathy in some of his talks. It's an injury that's now studied commonly and treated commonly in clinics for young teenagers, but previously this was just an injury type that had rare cases in adolescents, and people published them in the 90s as interesting case reports when you had patellar tendinopathy in an adolescent. Now it's quite commonplace. The evidence associating sport specialization with injury has been so resounding that virtually every relevant academic society's position statement discourages against it. Jayanthi's also contributed a study in attempt to risk stratify other variables that might be confounders, because people argue perhaps sport specialization is just being confounded with increased volume of exercise or overscheduling or things like this. This study of over 1,200 young athletes found injury risk to be associated with specialization degree, and this was irrespective of hours per week of the activity in their primary sport, and also irrespective of the growth rates in injured patients. They also found that participating in a single sport for more hours per week than a child's age was associated with significantly increased risk for overuse injury. So based on that study, the meta-analysis study, and some of the position statements from the societies I previously mentioned, I consider these rules of thumb when I'm counseling parents to be essentially a form of harm reduction for parents who are apparently committed to sport specialization for their child. I described that their child is more likely to need to come see me for injury in clinic if they're breaking these rules, and we'll go through their schedules and talk about doctor's notes for missing practices if needed and things like this. But we're using this evidence to give the rules of thumb that we're at risk for injury on the weeks that we're playing more hours per week than our age and years, if we're not taking 2 days off from our primary sport per week, and or if we are not having at least one off season per year. So that looks like 3 to 4 months where you're not in competitions, you're not trying to set personal records or focus on performance metrics, you're not trying to achieve something new that in terms of straining yourself to try and hit something new. This can be very widely applicable to different sports, but especially the individual sports. And then during that off season, we're thinking more about free play, rehabilitation and prehabilitation for injuries or biomechanical deficiencies that we're aware of, rest and recovery if needed from your end of your previous season, and focusing on fundamentals and some of the conditioning aspects that we don't get to focus on too much during competition season. Okay, next we'll talk about burnout. Though this isn't technically an injury, taking care of adolescent athletes almost always involves addressing some aspect of their psychosocial factors and or their mental health. Following the pandemic, adolescent anxiety and depression has skyrocketed, and athletes are not immune to this. With return to sport, things like resuming routines and scheduling, for some students, overscheduling, stress, and fatigue are important aspects of a student athlete's life to think about. This dovetails nicely with the discussion that we had about sport specialization, and I think about the athlete whose profile sounds like an elite type A patient with a motivated parent as well at risk for burnout. We describe the concept of non-functional overreaching when an athlete is putting in more and more hours but not seeing performance improvements. And this athlete is at higher risk for injury and for withdrawal from sport. We also describe overtraining syndrome, which is an interesting multifactorial phenomena where an athlete who's pushing too hard for too long can present like a patient with mood disturbances, cognitive issues manifesting with problems with school, frequent illness, frequent injury, and overall with complaints of fatigue. Similarly to our stress fracture patients who often have similar profiles to the patients that are at risk for these kind of burnout and overtraining, our treatment for these patients is rest until your symptoms improve and essentially until sports seem fun again. Unfortunately, sport specialization has also been objectively associated with burnout in large studies of thousands of youth athletes. I describe to patients who are still exploring sport options or with young children who are still trying to find new sports to encourage them to keep sports sampling. The concept of the fitness paradox is a powerful one, illustrated a little bit more on the next slide. So the fitness paradox, people who are active and healthy as children are more likely to become active and healthy as adults, and vice versa. Children who are sedentary are likely to become sedentary adults. A paradoxical outcome for imagine an elite athlete child who's specialized in a sport, but burning out, getting injured, or both, withdrawing from sport, and then becoming a sedentary adult because withdrawal from a single sport is their only sport and it gives them identity as an athlete, and that means withdrawal from physical activity in general. So when I'm speaking with parents about sports participation and injury prevention especially, I try to highlight the many positive aspects of sports and physical activity other than potential future financial success. Longevity in sport and physical activity, in my opinion, is the meaning of life, and it's the key to a long and a happy one. But longevity in sport does not mean playing in the NBA. I'll leave you with some really excellent resources. I encourage you to explore more. I use these to source my talk. We didn't have time to explore fracture management or specialization to the greatest depth. I also had to admit concussion care for adolescents just for time, but I would look forward to providing talks on these topics or anything else sports medicine that you might be interested in the future. I want to thank everybody for your interest today, and I'd love to answer any questions that came up during the talk.